Thank you, Eric. Our final speaker is someone who I've become acquainted through another activity here at the National Academies, the Global Forum on Health Professions Education, and that's Dr. Deborah Trautman. Dr. Trautman is the president and CEO of the American Association of Colleges of Nursing. She also has represented the field of nursing for the Interprofessional Education Consortium, or IAPEC, and currently serves as their chair. So we will next hear from her, and then we will open the floor up for questions and for discussion. Deb.
Thank you very much. It's an honor to be here with this great panel. I appreciate the interest, the expertise, and the commitment of everyone in the room. Being the last speaker, since I had to share something personal, I thought my personal hopefully will bring a little bit of a smile, but it is sharing a bit more about myself. When I graduated, like Dr. Farrell, I had a cap, but it wasn't worn frequently in practice. However, I decided to wear my cap when I first started practicing. And a colleague came up to me in orientation and said, "You're wearing your cap. You must be really proud of your program." And I said, "Oh, I am. I'm extremely proud of my nursing program. It was a great program." But I, too, did not get good content, though, on end-of-life care or palliative care. But nonetheless, anyway, I was wearing my cap. And before the orientation was over, and my colleague said to me, "You're wearing your cap because you're proud of your program," and I was. But I said, "But that's not the reason I'm wearing the cap." I said, "I'm wearing the cap because I'm new. I'm transitioning to practice, and I was one of the few people wearing a cap." So they'd be like, "Who's that nurse with the cap?" "Oh, that's the new nurse." So I thought it would help manage the expectations a little bit about me. But fast forward a little bit, before the orientation's over, I take off the cap. And the same colleague came up to me and they said, "Oh, I'm so glad to see you. You must be feeling more confident." And I said, "Well, I am. This orientation has been spectacular, but that's not the reason I took off the cap." They said, "Why?" I said, "It's for my own well-being." They said, "Why is that?" I'm 5'8". The rooms were crowded. My head kept getting cut. But in seriousness, I mean, my program was great. It prepared us for a lot. And it was a while back, but not that far back, not in the Florence Nightingale days. And we did not do enough to prepare the profession. And I am pleased to report that we have done increasingly more, but there is still so much more for us to do. So I want to share a little bit about our past, the present, and what we think is important for the future. As has been mentioned, we have an extraordinary partnership with the City of Hope. The leadership of Dr. Farrell, Dr. Pam Malloy, and many others, that leadership, the commitment, the excellence, setting standards for excellence and providing care at end-of-life palliative care, extremely important. One of the first pieces of work that was done at AACN was funded by the Robert Wood Johnson Foundation, and that was in 1997-98. Convened a roundtable, and at that time developed the Peaceful Death document. That document still exists and has been, as you can imagine, updated over the course of time, most recently in 2019. We also now have competencies like the other professions, and I'll speak a little bit more about where they are and where we expect competencies to continue to evolve, but for undergraduate and now graduate nursing education. And there is international work that is being done as well that Dr. Farrell shared within nursing, primarily through ELNEC. It's also already been mentioned, and most in the room know, that nurses have the privilege of being one of the healthcare professionals that do spend the most or more time with patients and at the bedside, at the community, in the communities, and with families than maybe other professions have the opportunity to do. But I would say it's not just that we have this opportunity, we have a responsibility then to take advantage of that time that we have and make sure that we capitalize and that we can initiate and continue what is sometimes very difficult conversations. So the essentials, these are the standards that are set for nursing education. And we currently have baccalaureate, master's, and essentials for the DNP, the Doctor of Nursing Practice. The point that I want to make about the essentials is that while these set standards and they help guide curricular, just has actually been already said by Dr. Holcomb, that it's not the standards, it's how our schools are going to implement the curricula, implement evaluation processes, implement the entire teaching process to assure that our students and then ultimately our graduates have the competencies they need. But it is important to be clear in these essentials. So these are the current essentials. Now I will come back to it a little bit later, but we're in the process of re-envisioning them, and I'm excited about what that's going to be, and I'll speak to that. But currently we do have very explicitly in these essentials, this is just one part abstracted, there's more detail in there, but the importance of implementing, as you can see, patient and family care around resolution of end-of-life and palliative care issues, and then with some examples, symptom management, supportive rituals, respect for preferences. So as I mentioned, we had the 1998 Peaceful Death Competencies, recognizing nurses are in the forefront, but knowing too that there's a limitation. The competencies that we established, they only direct, and we really need to continue to build the expertise and the commitment across the profession that we all have to have an understanding and continuously evolve our learning, our comfort, and our expertise in helping those who are coping with serious illness. AACN's board has worked with our membership, but with others, to continue to recognize this is not just one profession. As we know, we've heard the importance of interprofessional, and that there's opportunities for all of us to, in team-based care, support the work that we each do, and really, again, strengthen the opportunity to provide better health care, but ultimately a better environment for the individuals. I know that everyone in this room knows this already, but it is an expectation. Most of the care, as we know in the future, is not going to be delivered in the hospital, but still there is a significant amount of end-of-life care of people with serious illness that are in the hospital or unable to be in the home. The good news is that more health systems are creating palliative care programs. We know that the expectations are high, and unlike me wearing my cap, we do expect our graduates to be competent, and I don't want to misspeak there. But we have to make sure also that we're supporting each other, because while we're having and challenging ourselves, and we've been working on some case studies with our students and some simulation experiences, we need to support each other as well, and helping us not only be as skillful as we can in interacting with patients, families, and communities, but that we support each other as health professions and recognize when we are challenged personally by some of these situations that we face. So there are many barriers that we have overcome, but yet many more, I believe, that we still face. So I'm not sure what happened. Oh, I don't know why my S went down like that, but anyway, for nursing faculty preparedness, we are increasingly more faculty are prepared, but I want to mention when we first, in 1998, when we did that first document, we looked at the time, did a study to look at some of the text and other references that were being utilized in nursing programs across the country. And I should have mentioned earlier, AACN has 825 schools that are members, but when we looked at what was occurring across the country with faculty preparedness and the information we were providing to students at the time, only less than 2% of the content at that time included information that was relevant to palliative care or end of life. We recently, in 2014, looked again, and the good news was, if you call it that, the content increased to about 19%. But the bad news was much of that content was out of date and or just not accurate. And that still is a significant problem. So we must make sure that not only are we providing education, but that the ongoing continuing education has the most current and up-to-date information. There are resources that are lacking. I have seen some extraordinary simulation labs in the schools of nursing across the country, and then I have seen some that are back to my days of Annie, are you okay? We just have tremendous variation. Not everyone can and does benefit by online learning, but we are certainly seeing the quality of online learning has also significantly improved. As in every health profession, but most certainly in nursing, there's only so much that you can put into the curriculum. What we have all in nursing come to understand and appreciate is that while we must understand how to do something, increasingly more for all health professionals in the future, it's going to be more important how we think than specifically what we do. And so we have to continue to emphasize some of these key concepts as we're developing our critical thinking and thinking more about, again, these contributions we make. And then again, there's outdated, this is textbooks, but there's many outdated resources. You also know that as we have the web more available, one of the roles that we all must play is helping patients, families, communities navigate, because not everything that someone's able to download is going to be factual, is going to be evidence-based. And so we have to help advocate and on behalf, of the patients and families, helping them understand the information that is available to them. So I did, as Betty offered, I spoke a little bit more about ELNEC. And just so you know, the board has historically, in 2016, we endorsed the competencies. The curriculums have been developed and made available. It's been previously mentioned, but now over 330 schools of nursing are using the ELNEC curriculum. But again, remember, I told you 825 schools are AACN members. So that's not still widespread adoption, but it is increasing. But I want to assure you, though, that because it's in the essentials, it is, if the school is accredited by CCNE, then they must demonstrate, whether they use ELNEC or another strategy, they must demonstrate that the students are receiving this content and, more importantly, are developing the competencies. And again, also in the graduate programs, we have some information about the modules themselves, which have received very high reviews, continue to be revised as indicated, but they include testimonials, case studies. For nursing, many of you may be familiar, the NCLEX is the exam that we currently use. NCLEX is going to be changing from the process that we had previously used to be more of a test of the decision-making abilities of the nurse. Not so much is the answer A, B, C, or D, but really what, tracing a path so that there's not a only right or wrong. And I think that will help us in an area like this. And again, looking at both pediatric all the way through geriatric. Now, some of the successes from some of our stellar schools, and many of them have, it's not, as was said previously, there's not a one-size-fits-all. There are multiple pathways for us to consider in how we assure that the students receive this content. So these are just some examples, but we are seeing increasingly more, as I believe most other health professions, flipped classrooms and how students then really are grasping some of this content in a way that, quite frankly, was more passive clearly before. Just more data, the good news, 48 of the 50 states are and have used ELNEC, so we just have 2 more that we want to get to. But again, ELNEC is such a great program, and we do want to try and assure that we've done everything we could to minimize the barriers that would prevent a program from utilizing that. And the student completion is over 30,000, as you can see here. This is very small, but this slide is just intended to show that the feedback is consistent, and it's been very positive from those who have benefited by this type of education. Overall, the content's relevant, it's presented effectively, and people have increased confidence and changed their practice, even more so than the confidence. So I mentioned, again, there are multiple accreditors in nursing. CCNE is only one of them, but CCNE does accredit 86% of the baccalaureate programs. So we do have confidence that the content is now, unlike when I graduated, a much more consistent component of our education. But I did mention also that we're evolving. So just some information. Again, this is data that you've seen before, but there's a national and, of course, international interest. And ELNEC, again, has just been phenomenal in what it has done not only in the U.S., but worldwide. And our essentials are not worldwide yet, but they do actually help set the standards. And so we are in this process now of re-envisioning the essentials. And what I think is too soon to say, because AACN's membership has not voted yet, we've just begun to unveil them, but very similar to what our colleagues in medicine have done, is focusing on competency-based education. So not so much the time in the seat, but really demonstrating the competencies that the graduate must know and be able to demonstrate to effectively provide care. And we, like medicine, expect to see leveling. We will have domains incorporated in multiple domains will be the importance of palliative and end-of-life care. So there will be more detail that we will be able to present if you all were doing this a year from now with respect to both the competencies and the sub-competencies. But I believe that it is a very positive direction for us to go in, and that it will respect that we're all different learners, but at the end of the day, there are core competencies that we must be able to demonstrate is critical to the success of the care that we provide patients and communities. So there'll be ongoing continuing commitment. AACN's board has supported the work of ELNEC, as well as making sure, again, that our schools, whether they're utilizing the ELNEC curriculum or not, focus on and ensure that they're including this content in curriculum. And then a website where you can link to AACN's website, but also if you just type in ELNEC, that gives you more specific about this particular program. But I would just close by saying that our commitment is strong, and that we recognize that while we have come a considerable distance, there is still so much further that we need to go. I, too, as Eric shared, I have an aging parent, and I have been struck by the lack of care coordination, the lack of good communication. Betty's slide that was just extraordinary about what we all want, what we all expect, that should be the norm. And I believe we each have a commitment to do our best to step it up and make sure that we're more consistent in that regard. So I thank you for your time. Thank you very much.